cancer genetics. My question to you is, any investigation around the genetics for the native, West African blacks and the breast cancer of the African Americans, and to see whether over the generations some of the factors may have played a role in one role or the other in what we're seeing today. Thank you.
Glad this presentation you made about the disparity in the triple negative, because for a long time those of us from Nigeria and people in Ghana have been, we are told that it's all preparation error. We have lots of triple negative and yet we've been struggling. I say it's preparation error, preparation error. Now we have credible studies showing indeed that there's a big difference between triple negative rates in Africa, at least parts of Africa, and the developed world. And I think this is important. But I want to ask, did you consider this, and what measures did you take to show that this really is truly a difference about processing error?
Looking into the internal organs and innovations in optics and instrumentation and video technology incorporated into surgery has given birth to laparoscopy, and in summary, the surgeon sacrifices his wrist and tactile feedback for the immense benefit of precision and the other benefits that have been mentioned earlier. It's an essential skill to have in contemporary surgical practice. The scope, as had been said earlier, it cuts across different subspecialties of surgery, all those involved in the abdomen, and in line with my talk, giving practical tips, for beginners, it's very key to have a respect for your colleagues, because if you don't have enough cases, a quick way is having a good relationship with those across other specialties. And when they have cases, they can call you, and you improve your skills. So it involves general surgery, pediatric surgery, urology, gynecology and obstetrics, and the thoracic and vascular surgeons. The benefits has been highlighted earlier. In general surgery, there's a limitless scope of procedures that can be done laparoscopically, but practically, I have put up those ones that will give enough cases and enough time for beginners to build their skills and be competent enough to do more complex surgeries. So diagnostic dilemmas and acute appendicitis, gallbladder, gallstone diseases, intra-abdominal cancers, postoperative small bowel adhesion, hemodynamically stable abdominal trauma, and cyst and abscess drainage and ventral abdominal hernias. The abdomen is a Pandora box. It's a temple of surprises. And then imaging studies many a times are not able to accurately diagnose chronic abdominal or recurrent abdominal painful conditions. In comes laparoscopy, which is safe but invasive, and is simple when you have the requisite skill, and is a rapid way of having a quick having your diagnosis. I like to lay emphasis on its application in acute and subacute appendicitis, because globally, appendicitis is the most common surgical emergency, and that means in the West African sub-region we have a pool of cases, just like every other place. And the decision, for this region, the decision to operate is mostly clinically based, and oftentimes ultrasound is used. Advanced imaging studies, CT and MRI for perforated appendicitis are not routinely done. So laparoscopy is an effective tool. A study we did showed that it's the residents that do most of the appendectomies. There's the senior registrars and the registrars. So is a veritable tool to impart the basic laparoscopic skills. The stages involved first mobilizing the mesoappendix, creating a window, and then several methods of securing the mesoappendix. The quick and easy stapler device is quite expensive. Many centers who are around the region have diatomy units, so monopolar coagulation is a veritable tool for securing the mesoappendix after putting your sutures to extracorporeal sutures to secure the mesoappendix, and then cutting, and then putting a pre-tie loop to the base of the appendix. So this is a basic mode of doing a laparoscopic appendectomy, and like you know, there are more sophisticated methods. Gallbladder disease has been the flagship of laparoscopic surgery in the West, but in West African sub-region is not as common. And then in many centers, you find out that you have many tertiary centers. I'll be talking from two sides of my mouth. That's from the tertiary public sector and private sector. So just bear with me. In the public sector, or let's put it this way, it's not readily available. The pathology is not common, and but it's been documented that in centers where you're able to pool cases, that really it improves patient satisfaction. A case in point is Bafemi Awolowo University. My good friend Adisa has done quite a bit there. So, like I was saying, in other centers where you have multiple general surgery units, it's a bit of a challenge pulling enough cases for beginners to perfect their skills. So they have to fall back on workshops and other areas. That's why I mentioned the need to partner with other specialties so that a beginner can have his skills continually updated, and when it comes to laparoscopic cholecystectomy, that skill will be brought to bear. Intra-abdominal cancers is useful for diagnosis, as the acidic fluid can be aspirated, sent for cytology, or there can be a peritoneal wash in the absence of peritoneal metastasis and obvious lymph nodes, but the strong radiological suspicion of cancer, a peritoneal cytology helps in staging. Sometimes after staging, the patient is upstaged. You have a case where somebody is like stage 2 of gastric CA, and with laparoscopy, you discover that is stage 4. Then that obviates the need for your surgical intervention, and you're more likely to rely on chemotherapy and so on. Core biopsy and tissue biopsies are also achievable. Staging, like I said, there are micrometastases sometimes which are metastases which sometimes are radiologically occult, and laparoscopy plays a huge role in this. And for conditions like colorectal cancer, it can be used for stomach creation. That's the laparoscope in the abdomen clearly locates the site for the stomach, and by a combination of the an incision is made and it can be exteriorized, and that makes it quite rapid for a patient who is compromised physiologically. Post-operative small bowel adhesion is another significant role that the laparoscopy can play. Now, generally, there is a place for conservative management for small bowel obstruction, and then the traditional teaching is a laparotomy. Now that gives you the prospect of having further post-operative adhesion. So the place for a quick look. Now there are different, in the absence of complex adhesions which are suggestive of complex adhesions of cancer or evidence of ischemia, which are a bit obvious from the persistence of pain and the fever and vital signs changing. Excluding those, a quick laparoscopy, anterovisceral adhesions and viscerovisceral adhesions can easily be resolved by laparoscopic intervention. In abdominal trauma, straight up, if there's a symptomatic evidence of peritonitis, evisceration, free peritoneal gas and all that, so immediate surgical intervention, open surgical intervention is advised. But a lot has been said about the place of laparoscopy in trauma, but one thing is agreed on, which is for hemodynamically stable patients. Asymptomatic patients with thoracoabdominal injuries also. So abscess, pyogenic abscess, ventral abdominal, I just mentioned it, but because of the mesh, the composite mesh which is needed, and the mesh fixator and all that makes it a bit difficult to argue for that. In pediatric surgery, there are common useful applications, undescended testes for diagnosis and sexual differentiation. Inguinal hernia is quite simple, and it's easy to diagnose a contralateral hernia, and the others are there. In urology, varicocele, you're able to do that with laparoscopy and other interventions. There's laparoscopic nephrectomy and uretectomy and all that. Like I said, it all depends on where you are on the learning curve, and it is useful in urological emergencies. Urological malignancies. Gynecology and obstetrics, it gives a panoramic view of the pelvis. The uterine manipulator is so essential. There are several applications of it. Work closely with a gynecologist who has an interest, and we've been able to do quite a bit. Even in non-obstetric laparoscopic surgery in pregnancy, there are just a few tips to it. One is preoperative preparation. I mean, if radiation is required as an X-ray or CT, there's a bit of concern for the baby. Anesthesia, there's a very major need for an obstetric anesthetist, and the positioning of the patient, pressure of the gravid uterus on the major vessels, access. The typical access in a virginal abdomen of the umbilicus needs to be reevaluated. That's depending on the size of the uterus, and a bit of added considerations. Challenges: training, team, tools. 3 T's. Training, there's need for ongoing training and training of beginners, training of retraining of those who already have the skills. For some reason or the other, it's not. The team, as been mentioned, is so useful. You need the anesthetic, you have to work with everybody. The tools, having the complete set and maintaining them. Cost is an ever-present factor in our sub-region. Awareness, there's a study in Ghana saying that it's not really very well known amongst patients, and we did one saying amongst practitioners too. So in conclusion, skill-wise, everybody is on the learning curve, and you need to know where you are. And a careful patient selection and adequate preparation are hallmarks of safe laparoscopic surgery. Thank you so much for listening.
Thank you very much. All right.